Hello everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in an academy. I have an experience of teaching undergraduate and postgraduate medical students, and I've done my MBBS and MD from Rajiv Gandhi University of Health Sciences. So today we are discussing about thalassemia. So in detail, we'll be discussing on the pathophysiology, the clinical features, the investigations, and the management of thalassemia. Okay, so before that, I would want to talk about a little bit about Unacademy. Unacademy is India's largest online learning platform. There are a lot of benefits you can avail from this platform. Firstly, the daily live classes. So there are various educators in this platform who have daily classes in this over here, and you can attend your favorite educator's class and engage in discussion, ask your doubts, and these doubts will be immediately cleared in the live chat box. Also, coming to the structured course. So whenever you're preparing for any entrance exam, you need to have a structured approach. You need to plan really well. So by the time you give your exam, you would have to revise so that you remember better. So here in an academy, all our courses are structured in line with your exam syllabus. That is the NEET PG. And this will be a huge boost for your preparation. Also the live tests and quizzes. So again, when you're preparing for an entrance exam, you need to evaluate yourself. You need to know what are your weak areas, what are your strong areas, right? So once you analyze yourself, you can concentrate on the topics which are weak at. So here in an academy, there are regular live tests and quizzes happening, and this helps you to evaluate yourself and analyze your performance better. Okay, so as a result, you can concentrate on the topics which you might not be as good at. Next is the unlimited access. So once you subscribe to the subscription, you get unlimited access to all the classes which are exclusive to the subscription platform. Okay, so even if you have missed a live class, you can go back and watch these recorded classes again and again. All this in the comfort of your home, in the comfort of your own device. So I would highly recommend this platform, and using this platform in the beginning part of your preparation will take you a long way. These are the top educators in the platform, and they have regular classes happening. You can go and attend their classes as well. Okay, and all the 19 subjects required for NEET PG preparation are taught in this platform. Okay, so and this is the NEET PG subscription package. So as you can see, the NEET PG subscription package varies from 1 month to 2 years. So I would suggest the 1 year or the 2 year subscription. But the ones who are giving their NEET PG 2021, for them the 6 month subscription would suffice. Okay, the 6 month subscription costs you 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 18,000. Okay, the 1 year or the 2 year subscription, especially to the students who are in their third year MBBS, final year MBBS, or the ones who are in their internship, for them the 1 year or the 2 year subscription becomes very reasonable also. Okay, so if it's a 1 year subscription, you'll be actually paying only 2,083 rupees per month, and it will come up to a cost of 25,000. But if you use my code 10 Shilpa 10, you get a 10% discount, and it will come up to 22,500. So even the per month subscription comes even less, that is 1,875. So 2 year subscription costs you 30,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 27,000. Okay, so I highly recommend this platform, and using this platform in the beginning part of your preparation will take you a long way. Okay, so now I will start with today's topic, that is thalassemia. Okay, so thalassemia, you need to know first how would the word thalassemia come. So this is a Greek word. Okay, it's a Greek word that is derived from thalassa. So thalassa means the sea, and anything related to emia means related to blood. Okay, that is how the meaning of thalassemia comes. So thalassa means the sea in Greek. Okay, and emia means which is related to blood. So the sea of blood. So something like, so that is how the name thalassemia comes. And this thalassemia occurs because of the globin chain gene defects. Globin chain gene defects. So remember, so in a hemoglobin A, HbA, this is the adult hemoglobin. Adult hemoglobin, you need alpha 2 and beta 2. Okay, so any absence in any of this globin chain will lead to thalassemia. So absence of alpha chain leads to alpha thalassemia, and absence of beta chain leads to beta thalassemia. Okay, so now coming to the pathophysiology. The first thing you need to know is the various hemoglobins. Okay, so what are the chains which form the various hemoglobins? So as I've told you, HbA. So hemoglobin A, that is the adult hemoglobin, that is formed by alpha 2 and the beta 2. Okay, HbA2. So in the adult hemoglobin, a small percentage of the hemoglobin will be HbA2. So that will be alpha 2, delta 2. Next is the fetal hemoglobin. So in the fetus, the hemoglobin is the HbF, that is a fetal hemoglobin, that is alpha 2 and the gamma 2. So generally this fetal hemoglobin will be present in the infant up to 6 to 1 month. So depends on the availability of the gamma chain. So it will be by 6 to 1 year, sorry, the fetal hemoglobin will be there. But in a child with thalassemia, as you know, one of the globin chain is affected. So especially the beta globin chain, because for the hemoglobin, fetal hemoglobin, you need alpha. So when the beta globin chain is affected, this in thalassemia, this fetal hemoglobin, the delay in disappear there will be delay in disappearance of the fetal hemoglobin, because uh, these children need some form of support, right? So that is why in case of thalassemia there is delay in disappearance of the fetal hemoglobin. Okay, so now we'll talk about the pathophysiology in beta thalassemia. So in beta thalassemia, you should know about beta 0 and beta plus. So in beta 0, what happens is there is complete absence of the production of beta chain. There is complete absence. In beta plus, there is abnormal production. So maybe decreased production, but there is some beta globin chain. Okay. So as you all know, beta 0 is complete absence. So that means what? Yeah, so normally from the fetal hemoglobin to the adult hemoglobin, it takes around 6 months to 1 year. Okay, Ganesh? 6 months to 1 year. So in thalassemia, that transition from the fetal hemoglobin to the adult hemoglobin is delayed. Fine. Okay, so so I said, so when there is in beta 0, you see what, there is complete absence of production of beta chain. So as a result, this becomes a more severe beta thalassemia. Fine. So now coming to the pathophysiology of beta thalassemia. So now what happens? There is no beta globin chains happening. So there will be increased production of alpha chains. Okay. Basically, there will be, compared to the beta chain, there will be more of alpha chains. Okay. So there will be alpha chain will be in excess. Alpha globin chain will be in excess compared to the other non-alpha globin chains like the beta, the delta, gamma. So alpha. So what happens to this alpha globin chains is there will be alpha globin tetramers which are formed. That means four molecules. There will be alpha globin tetramers which are formed. Alpha globin tetramers. So this alpha globin tetramers, what happens? They will present as inclusions in the red cell, red blood cell. Okay, they will present as a inclusion in RBC. Okay, so now what happens? This inclusion are very unstable and they will precipitate, and then they will cause damage to the red cell membranes. Okay, so they will damage the red cell membrane. Okay, as it is unstable and precipitates. Okay, and therefore this abnormal erythrocyte or the erythroblast will get destroyed in the spleen. in the spleen. Okay, now this destruction of the RBCs in the spleen will lead to anemia. So what happens when there is anemia? There will be tissue anoxia. So when there is tissue anoxia, there will be increase in erythropoietin levels. So as a result, there will be bone marrow expansion. There will be increase in the there will be increase demand for the production of RBCs. So the marrow will start producing more RBCs. Okay, so there is, and as a result, there will be bone marrow the expansion will be there. Marrow expansion occurs, and this will cause skeletal deformities. And another thing you should know is, when these RBCs are formed, so when these RBCs are formed in the bone marrow, most of the RBCs in thalassemia are destroyed in the marrow itself, and as a result there is ineffective erythropoiesis. Okay, the ones which escape out becomes this alpha globin tetramers and will be abnormal RBCs, right? So there will be ineffective erythropoiesis. So another thing is, when there is anemia, what do? We give blood transfusion. This blood transfusion, there is a chronic blood transfusion required in a child with thalassemia, and as a result, this will lead to iron overload in various organs. Okay, so this is the pathophysiology. Okay, so very important you should know is, in thalassemia there is ineffective erythropoiesis. That means the RBCs which are produced in the bone marrow are destroyed in the bone marrow itself, and only the few abnormal RBCs go outside, and that also they'll die soon because they are abnormal and they are destroyed in the spleen. So this you should know. Okay, and because of this, so though there is so much RBCs formed, there is something called as relative reticulocytopenia. So though the reticulocytes are formed, for the amount of destruction in the spleen happening, there is the reticulocytes are not so much seen uh, in the blood. Okay, so the reticulocyte count is generally less than 8%, though it is a high retic count, but for the hemolysis what is happening in thalassemia, it is still less. Okay, so the retic count is generally less than 8%, between 5 to 8%. Okay, so this is about the pathophysiology of beta thalassemia. So now coming to alpha thalassemia. So now tell me, in alpha thalassemia what happens? So now in alpha thalassemia, there is no production of alpha globin chains, right? There is no production of alpha globin chains. And I have told you, the fetal HbF, the fetal hemoglobin, needs alpha, that is alpha 2 and gamma 2. It needs alpha globin chains. Now a child, the fetus, if the fetus has alpha thalassemia, there is no alpha chain. Okay, there is no alpha globin chain happening. So these children will present intrauterine itself. So these children can have hydrops fetalis when there is complete absence of globin production, alpha globin production, or they will be alpha thalassemia silent carriers if there is reduced production of alpha globin chains. So in case of complete absence of alpha globin chains, these children will have, there will be fetal death in such conditions, because The oxygen is not there is no oxygen to be maintained in this fetus, so this becomes a severe form, alpha thalassemia. So alpha globin chain is very important even for the fetal hemoglobin. So when that is not there, that is completely absent, these children will have hydrops fetalis and eventually death. Okay, fine. So in case of beta thalassemia, what happens? These children will not have any antenatal, fetuses will be normal, they will present only after birth. Fine. So did you get? So out of beta thalassemia and alpha thalassemia becomes even more dangerous. Fine. So in the beta thalassemia, I've said that it's beta 0 and beta plus. So in beta 0, compared to this, both the type of thalassemia, beta 0 is more severe. Fine. So now coming to the clinical features. So in this, what happens? So till the HB fetal hemoglobin is there, these children might not even present. Okay, they might not present till the fetal hemoglobin is there. So once this starts decreasing, these children will have anemia, they'll have anemia. Okay, there will be growth failure because there is ineffective erythropoiesis in these children. There will be growth failure. There will be bony deformities. There will be organ, that is splenomegaly. Okay, so there is something called as thalassemic phases. So what is thalassemic phases? What is thalassemic phases? So thalassemic phases is these children will have a typical picture of hemolytic phases or chipmunk phases, it is called as. So remember, chipmunk phases. So these children will have maxilla will be, there will be hyperplasia. There will be maxilla hyperplasia. So this part, it will be protruding out. Okay, this part, maxilla hyperplasia. Next, they'll have a flattened nasal bridge. And they'll have frontal bossing. This is typical of children with thalassemia. So when you look at a child who has thalassemia, you will know this is a typical chipmunk phases or thalassemic phases, and this child has certain hemolytic anemia. Okay, so looking at the child itself, you can guess the disease. Okay, so now based on the anemia, so in case, so there is thalassemia intermedia. So here what happens is there is anemia, but it is not transfusion dependent. While thalassemia major will have severe anemia, there will be severe anemia and the child will be transfusion dependent. So now what happens? So now when there is severe, the child is requiring transfusion. So when there is chronic transfusion dependency, what happens? There will be iron overload. Right? So this iron overload can go and lead to deposit in various organs. So and as a result, there will be liver hemosiderosis. So first the iron goes and deposits in the liver. Okay, so in the 1 year of transfusion, the child will have hemosiderosis, liver hemosiderosis. and slowly it will lead to other organs. Okay, so these children, because of the deposition into the endocrine glands and all that, these children have a high chance of developing hypothyroidism, hypogonadotrophic gonadism, growth hormone deficiency, diabetes mellitus, hypoparathyroidism. So this transfusion, if it goes beyond 10 years, there will be even cardiac deposition of iron. There will be cardiac deposition of iron. Okay, so you should remember that. And that is why chelation. What kind of skin pigmentation? Because of thalassemia per se, as such, no skin pigmentation is a feature of thalassemia. Okay, only in vitamin B12 deficiency there is this knuckle pigmentation. Maybe that bronze look might be there because of the iron, but it is not a complete feature. So don't go for the skin pigmentation part. It will only deviate you from the topic. Okay, no skin pigmentation. Okay, so cardiac deposition of iron. So this is the main thing what happens. Okay, so next. So this is the child with the chipmunk faces. So you can see there is maxillary hyperplasia which has happened. Okay, so there is this the maxilla which has protruded out. Okay, there is mild frontal bossing which you can see. There is mild frontal bossing, and then you can see there is a flat nasal bridge. So this is the typical picture of chipmunk faces or thalassemic faces. Fine. So now coming to the various spectrum of beta thalassemia. So you know there is beta thalassemic trait. So over here what happens, these children will have mild anemia. Okay, and when you get a HB electrophoresis, you will see there is increased levels of either HbA2 or HbF or both. When you get a HB electrophoresis in a child with beta thalassemia trait. Okay, so next I have told you thalassemia intermedia. Over here what happens, these children have anemia and of various severity, but they are not transfusion dependent. Okay, they are not transfusion dependent. They are not transfusion dependent, and slowly these children will eventually, because of the hemolysis, there will be icterus and there will be splenomegaly. Okay, so this you should know. Next, coming to the thalassemia major. Over here there is severe anemia. They will require blood transfusion. There is all these other features which we'll see. You will see bony abnormalities. There will be growth failure in these children. Okay, so another thing you should know is this beta thalassemia with beta chain structural variant. So over here these children will have beta thalassemia, along with it there is something called as HbE. So these can be various presentations from severe to mild. Okay, this you should know. HbE, association with HbE. So when you get a laboratory test, so what first you can do? First you will do an HB electrophoresis. So here there will be elevated increased HbF, increased HbA2 compared to HbA. So HbA will be decreased. Okay. So in a normal human, like even a older child, the HbA accounts to 95 to 98%, while HbA2 is around 2%. Okay, so this is the normal electrophoresis picture you should have. So here in when you get an HP electrophoresis, there is increase in the fetal hemoglobin and the increase in HbA2. So next is when you get MCV. So see, when you get a CBC, MCV will be decreased. Okay, and MCH also will be decreased. There is microcytosis and there is hypochromia. So the peripheral smear will show microcytic hypochromic anemia. And there is a lot of fragmented cells, RBCs, which you see. There is a lot of fragmented RBCs, which you will see. Okay, so this is about this thing. And then the retic count, I have told you, because of the ineffective erythropoiesis, there is relative reticulocytopenia. Okay, so the count is, retic count is between 5 to 8%, so generally less than 8%. So you should know about this. Another thing is, always it's better to get a DNA analysis or analysis for the thalassemic mutation. So this is the best thalassemic mutation. Okay, so this is the best test. Fine. Next. Anything else to be added, Ganesh? Okay, and also because of severe hemolysis, these children will have elevated bilirubin also, serum bilirubin also. So this is an unconjugated hyperbilirubinemia which you see here. Okay, so as you can see, this is a peripheral smear. Peripheral smear. So over here there is microcytes, which you see. You can see there are various fragmented cells. Okay, there are very fragmented cells you can see. So another thing is there is hypochromia, there is microcytosis, and then you see fragmented RBCs. So another thing what you can see is the color in some of it is little higher in this thing. So those are the reticulocytes. Okay, so that is called as polychromatophilia. Okay, so so certain, when there are retic counts, when there is retic counts, you can see. Okay, so another thing is what you have to keep in mind is uh, these children will have low retic count. I have told you because of 1 second. So yeah, target cells are also present, but target cells are generally present when there is beta thalassemia with HbE. Okay, so target cells are also present. Fine. So this is another picture of a radiological feature because of the increasing diploic space between the outer and the inner cortical bones. Okay, so over here you can see this fine trabecular trabecules like this. So that gives the hair on end appearance. So this is a very hair on end appearance. So this is the most very important typical feature of a child with thalassemia. Okay, hair on end appearance in thalassemia. Next, coming to the therapy. So again, I have told you, in children with thalassemia major, so in children with thalassemia major, they will need recurrent blood transfusion. So this recurrent blood transfusion can lead to children having iron overload. Okay, so that is another very important thing. So these children can go for iron overload. Okay, so these some children will require once in 3 weeks, some children might require once in 4 weeks. So iron overload monitoring you have to check by doing a serum ferritin level. So the serum ferritin level will give you an idea of tissue levels of iron. Okay, levels of tissue iron in the tissues. Another very important thing is getting a MRI. So non-invasive method, so an MRI technology which will tell you on how much iron is present in the liver. Okay, so that is done, and a T2 weighted MRI is done at around 10 years, at around 7 years of transfusion, to check for cardiac deposition of iron. Check for cardiac deposition of iron. Okay, T2 weighted MRI should be done at around 7 years of transfusion to check for cardiac deposition of iron. So because this is very important to check the the cardiac deposition, because these children, if not monitored for the cardiac deposition, they might die of cardiac failure, congestive cardiac failure, um, or because of cardiac arrhythmias. Next. So next, coming to the chelation therapy. So chelation therapy should be started when the ferritin level goes above. So when the ferritin level goes above 1000 nanogram. So that time you should start on chelation therapy. So in the chelation therapy, deferoxamine. So deferoxamine is the first drug, but over here this is very good and has a good safety profile, but it has to be given parenterally. Okay, so it has to be given parenterally, and it has either subcutaneous or IV. So this problem with this is it has a short life and has to be given 3 times a day. So remember, deferoxamine. So it is the only chelation drug out of the three which is have to be given parenterally. So in these children, what happens is because of the route of administration, there is non-compliance. So non-compliance because of the route of administration. The few side effects which we see, this has the best safety profile, but the few side effects which you see with deferoxamine is there could be ototoxicity. Okay, there could be ototoxicity, there could be certain retinal changes. Next, coming to the next drug, that is deferasirox. Okay, so deferasirox, so this is an oral drug. Okay, so this has a half-life of 16 hours. So this has a half-life of 16 hours, and this can be given once daily. Okay, so here the side effects are there is certain mild gastrointestinal irritation or symptoms. But one major thing about deferasirox is these patients can have kidney damage. They can have kidney damage. So these children should be monitored for any proteinuria. So regularly you have to get a urine test to get a proteinuria. So deferasirox, the only thing is these children can have a severe renal failure, or they can go for kidney damage. Next is the deferiprone. So in deferiprone, this is another oral chelator. So this is an oral chelator. So now this, what happens is this is very specific to the cardiac tissue. So it enters the cardiac tissue. It's a small molecule and it enters the cardiac tissue. Okay, and this is best in case of cardiac hemosiderosis. Okay, so this is very good if there is for cardiac hemosiderosis. But the side effect of this is there is agranulocytosis. So these children can have neutropenia, lymphopenia. So you have to get a regular monitoring of the CBC has to be done. So regular monitoring of the blood count should be done weekly. Weekly monitoring should be done. Yeah, so arthropathy also, yes, arthropathy is also there. Yes, yes. So next comes hydroxyurea. So this is a DNA antimetabolite. So what does this do is, so this is especially used in children with thalassemia intermedia to uh, thalassemia intermedia to retain the fetal hemoglobin, okay, so that the fetal hemoglobin production is increased. So this is a DNA metabolite, so to increase the fetal hemoglobin production. So that is how these children will get the oxygen. But the only thing about the fetal hemoglobin problem with the fetal, there is increased oxygen affinity to this, or to this hemoglobin, and as a result, it is not, the oxygen is not very easily released. Okay, so that is the only thing. But then there is no other option, because in children with thalassemia intermedia, you can avoid these children from going for blood transfusion. So hydroxyurea is a DNA metabolite, which DNA antimetabolite, sorry, which is used in thalassemia intermedia to increase the fetal hemoglobin production. So next comes the hematopoietic stem cell transfer. So this is very important. So especially this has around 90% survival, and there is 80% event-free survival. Okay, so this is done in children less than 15 years. So less than 15. So in children less than 15 years, you do hematopoietic stem cell transplant. So you have to get a HLA match, sibling HLA matched. So this is the best one, sibling HLA matched allogenic transplantation. Okay, so this is the best match. Splenectomy. So splenectomy is generally not done in thalassemia unless there is hypersplenism. There is increased destruction of the RBCs in the spleen, and the child is requiring and the child requires increased blood transfusion. Okay, so in a year, if the child requires 200 to 250 ml per kg of blood, okay, if the child requires more than 200 to 250 ml per kg of blood in a year, so these children will benefit from splenectomy. But the only problem with this is these children can, after going for splenectomy, they can have severe infection. So that is the only reason we avoid this. But a child who requires such high blood transfusions can have serious other problems as well. So as I've told you, there can be iron deposits, there can be, okay, so cardiac failure. And so whenever you do a blood transfusion also, it should be maintained well. So a proper blood transfusion which is done in a child, that only in such children the growth also will be normal. So a child who requires 200 to 250 ml per kg, more than that, of blood transfusion per year, these are candidates for splenectomy. So if there is hypersplenism or there is increased blood transfusion, then these children go for it's taken for splenectomy. But the best therapy is the hematopoietic stem cell transplant. So now I've told you what are the complications. So one, there could be osteopenia, there will be extra. So because of this high demand for the bone erythropoiesis, first of all, there is ineffective erythropoiesis. So these children will have extramedullary erythropoiesis. So tell me the sites of extramedullary erythropoiesis, like the liver, spleen, okay, the peritoneum. So these are the site. So what happens is these can present as mass. So these extra medullary erythropoiesis, there can be certain mass formation, and they can have a pressure effect on the various other organs as well. They can compress the they can compress the spinal cord also. So these are the complications because of the extramedullary erythropoiesis. They can have osteopenia. They can have because of the iron overload. So that is the treatment treatment because of the blood transfusion, iron overload. They can have endocrinal problems, right? Endocrine problems like they can have hypothyroidism. They can have hypogonadotrophic gonadism. They can have hypothyroidism. They can have hypoparathyroidism. They can have growth hormone deficiency. Right? So these can happen. Okay. So now, when coming to the intravascular, so I will do a few discussion on the intravascular. Yeah, diabetes mellitus. Yes, very good. So these are the endocrine problems. So now we'll do a little discussion on the yeah extravascular hemolysis and the intravascular hemolysis. So, what is extravascular hemolysis? The hemolysis happening in various other sites like the spleen and all that. So, the most common condition is so a child who has hemoglobinuria, if there is blood which you see in the urine, so such children will go for intravascular. That is another sign for intravascular hemolysis. So, you should know about that. Okay. So, hereditary pyrocytosis. So, basically the RBCs are spear. I mean, they're rounder, so they cannot mold when they go through a very tiny tubule. I mean, tiny space. So that is why these in hereditary spherocytosis there is uh, destruction of the RBCs in the spleen. Okay, so next, even pyruvate kinase. So yesterday I got by mistake I have told pyruvate kinase was intravascular. It is pyruvate kinase is extravascular hemolysis because the RBCs become rigid. So right, so the RBCs become rigid. So in here the G6PD deficiency is an intravascular hemolysis. So the thalassemia is extravascular. Okay, then even the sickle cell. So sickle cell anemia, around 1/3 of these patients can go. So 1/3 of these patients can go for what is it called, for intravascular hemolysis. Yeah, so basically what is super transfusion is, so super transfusion is you have to maintain the hemoglobin at one level. Okay, so in super transfusion, before the transfusion, you have to see that when the child's hemoglobin falls below 12, so when the child falls below 12, then you have to maintain between 12 to 14. So somewhere when the child's hemoglobin is 12, you do a transfusion and maintain it at 14. So that is called a super transfusion. So basically the hemoglobin of the child is maintained. You shouldn't go to such level. So if it goes below 10 or something, that can affect the growth of the child. So see that when the child is at 12, you do a super transfusion. Okay, and after that the hemoglobin should be maintained above 14. So that is super transfusion. Okay, so maintaining post the transfusion, maintaining a hemoglobin of more than 14 is called super transfusion. Okay, between 12 to 14. So the hemoglobin during the transfusion is above 12. So next, what was I saying? Sickle cell anemia has extra. So the reason for super transfusion is the child should not go to any complications of anemia like growth failure. Then there is bone marrow bone skeletal deformities and all that, so that the child doesn't go to such severe complications of thalassemia. Super transfusion is done. Okay. So sickle cell anemia is also a extravascular hemolysis. Okay. But 1/3 of these can have intravascular hemolysis. So tomorrow I'll be discussing about sickle cell anemia. So we'll discuss about this tomorrow. Okay. So most of the hemolytic anemia will end up is extracellular. So in G6PD, okay, G6PD and paroxysmal nocturnal hemoglobinuria, these become intravascular hemolysis. Fine. So now we'll have a fast revision of today's topic. So basically thalassemia is because there is a defect in the globin chain. So HbA, that is the adult hemoglobin, it has alpha 2 and beta 2. So any absence of these two globin chains leads to thalassemia. Okay. So pathophysiology, what you should know. So in case of beta thalassemia, the alpha globin chain will be in excess compared to the beta globin chain. So what happens, this alpha globin will make a tetramer. So this alpha globin tetramers will form as a inclusion in the red blood cells. So this inclusion is RBC inclusion is very unstable and it will precipitate in the RBC, and that will damage the cell membrane, and as a result this unstable or an abnormal RBC will get destroyed in the spleen, and as a result there is anemia, there is further tissue anoxia which will increase the erythropoietin stimulation for the bone marrow, and there will be bone marrow expansion and it will lead to skeletal deformities. Another thing we should remember is in these children, when there is excessive when there is increased production of RBCs in the marrow, in the bone marrow, that is the reticulocytes, they are in a very unstable form. So they are destroyed in the marrow itself. This leads to ineffective erythropoiesis. Okay. So this you should know. So in alpha thalassemia, so alpha globin chains are absent. So alpha globin is very important even for fetal hemoglobin formation. So since alpha globins are completely absent, that time these children will present in the intrauterine period itself. So they can have hydrops fetalis and fetal death eventually. But if there is a partial production of alpha globin chain, these children become as alpha thalassemia silent carriers. Okay, so this is because the alpha globin chain is very important for the production of fetal hemoglobin. So next is a clinical feature. So you all know there is anemia, there is growth failure, there is bony deformities. Main important thing is the thalassemia facies or the chipmunk facies. So there is maxillary hyperplasia, there is flat nasal bridge, then there is frontal bossing. Okay, so this you should know. And there is in thalassemia intermedia, the anemia is there, but they are not transfusion dependent. While in thalassemia major, there is severe anemia and they are transfusion dependent. Okay. Yeah, so basically in children who have thalassemia major, they require chronic blood transfusion. So this chronic blood transfusion will lead to iron overload. So by the 1 year of transfusion, there will be liver hemosiderosis. That means the liver is the iron is deposited in the liver. Okay, also following which there is this iron gets deposited in various other endocrine glands. So that results to hypothyroidism, hypogonadotropic gonadism, growth hormone deficiency, diabetes mellitus, hypoparathyroidism. So these are some of the complications you should know because of the iron deposition due to blood transfusion. As this blood transfusion carries on to up to 10 years, so there will be cardiac deposition of iron. So the one of the main reason in untreated children with chelation therapy, these children, the cause of death could be because of a congestive heart failure or because of cardiac arrhythmias, because of cardiac hemosiderosis. Fine. Next. So this is a child who has features of thalassemia. So thalassemic facies or the chipmunk facies. So you can see over here the hyperplasia of the maxilla. So there is protrusion of the maxillary bone, and then there is a flattened nasal flat nasal bridge. Okay, and you can also see the teeth is also protruding out. So that is a picture you should know for chipmunk faces. And mild frontal bossing you can see in this child. So this is a typical child with thalassemia. So next, coming to the spectrum. So I told you in beta thalassemic trait, these patients will have mild anemia. When you get they might not show any symptoms, but when you get an HB electrophoresis, what you will see is there is increase in the HbA2 and the HbF, or both. What should be the normal electrophoresis be? Normal electrophoresis should have HbA, which should account to at least 95 to 98%, and HbA2 accounts to around 2 to 3%. So this is how it should be, a normal HB electrophoresis. But in a child with beta thalassemic trait, when you get HB electrophoresis, there is increased HbA2, HbF, or both. In thalassemia intermedia, so this over here, they have anemia, but they are not transfusion dependent. Might be the need of transfusion will be in a long gap, so they are not as transfusion dependent as a child with thalassemia major. So these children, they will have jaundice, they will have splenomegaly. Okay, but in a child with thalassemia major, what happens? There is severe anemia, there is need of blood transfusion, there is bony abnormalities, there is growth failure. Okay, so this you should know. Next, coming to the laboratory features. So when you do a CBC, you see there is decreased MCV, there is decreased MCH. So RDW, what is the RDW in these children? So the RDW is normal. Okay, so you should know that. So when you get a peripheral smear, you see there is microcytic hypochromic anemia, there is fragmented RBCs, there is retic count. Okay, the retic count is between 5 to 8%. So that is why, so generally there is so much hemolysis happening, the retic count should be very high. But what you see is there is ineffective erythropoiesis in these children, and there is relative reticulocytopenia. So though this is a high retic count, but it is not as much correlating with the hemolysis which is happening. Okay, so DNA analysis to check the thalassemic mutation is the best test. Okay, so peripheral smear, you see hypochromia, microcytic cells, and there is fragmented RBCs. So this is a typical picture which you see in a child with thalassemia, that is the hair on end appearance. Next is the transfusion treatment. So in the treatment, transfusion is the first line which is given in these children. So 1 second. Yeah, so transfusion, especially in children with thalassemia major. Iron overload monitoring should be done in children who are on transfusion therapy. So iron overload, because the very important thing is the iron can deposit in various organs and can lead to the toxicity of iron. Okay, so serum ferritin is the best marker to tell the tissue iron concentration. Other tests which should be done is the MRI. So because the ferritin, the problem is if there is any other inflammatory condition, that time also ferritin will be raised. So you have to do some non-invasive methods to check for the iron in the tissue. So one is the MRI. So to check the liver concentration of iron, MRI is also very good. So there are various technologies now which tell you the concentration of the iron in these organs. And around 7 years of transfusion, you should do a T2 weighted MRI to check cardiac depositions of iron. So next, coming to the chelation therapy. So when the ferritin level is above 1000, you have to start with chelation therapy. So first is the deferoxamine. So this is a very safe drug, but the only disadvantage is the route of administration. It has to be either given subcutaneously or IV, and it has to be given 3 times a day because it has a very short half-life. Okay, so because the route of administration is parenteral, there is non-compliance to this therapy. Okay, so that is why oral drugs are preferred. So one of the side effects is the ototoxicity and the retinal changes. In deferoxarox, this is an oral drug and the half-life is 16 hours. It's enough to give once a day. The side effects, there is mild GI symptoms, but there could be severe kidney damage in these children. So you have to get check for proteinuria in these children regularly. Okay, so you have to get a urine analysis for protein to check if this child is going for any kidney damage. Next is deferriprone. So deferriprone is an oral chelator. This is especially a drug for cardiac hemosiderosis. So this enters the cardiac tissue. It's a small molecule which enters the cardiac tissue. Okay, and but the side effect of this is agranulocytosis. So in these children, you should do a weekly monitoring of the total count. Okay, so you should do. Next is the hydroxyurea. So hydroxyurea is a DNA anti-metabolite. It is used especially in children who have thalassemia intermedia, so that there is an increase in the fetal hemoglobin production. Okay, so you should remember so much. Next is the hematopoietic stem cell transplant. So there is a 90% survival in a child with thalassemia who undergoes hematopoietic stem cell transplant, and there is 80% event-free survival in these children, and this should be done in children less than 15 years. Sibling HLA matched allogenic transplant is the best. Okay, splenectomy is not usually done in children with thalassemia unless there is hypersplenism, there is increased demand for blood transfusion. So there is so much, the blood transfusion is so much high that it exceeds 200 to 250 ml per kg per year. So that much blood transfusion in a child will lead to severe iron toxicity. So that is why in such children they will benefit from splenectomy. Only if there is high requirement of blood transfusion and hypersplenism, children go for splenectomy is done. So coming to the complications, so first thing is osteopenia will be there. Secondly, there is extramedullary erythropoiesis. So there is so much demand for the RBCs to be formed. So there is ineffective erythropoiesis in the marrows. Along with that, there is extramedullary erythropoiesis happening. So when there is extramedullary erythropoiesis happening, there will be these masses which are produced in the body, and they will compress the various other organs. They can compress on the spine. Okay, so that is one of the complications of thalassemia. Next is the endocrine problem that happens because of the blood transfusion which we're doing in thalassemia. So chronic blood transfusion can lead to iron deposition in these various endocrine glands, and they can produce hypothyroidism, hypogonadotrophic gonadism, growth hormone deficiency, diabetes mellitus, hypoparathyroidism. So these are the various endocrine problems a child with thalassemia can face. Okay, so I wanted to clear this. So the extravascular and intravascular hemolysis in hemolytic anemia, you should know. So G6-PDP and that's paroxysmal nocturnal hemoglobinuria is intravascular. So hereditary spherocytes. So basically extravascular hemolysis is the destruction of the RBCs happening outside in various other like the spleen or in the liver. So that is extravascular hemolysis, not in the blood. So hereditary spherocytosis, pyruvate kinase deficiency, thalassemia, sickle cell anemia are all features of extravascular hemolysis. A small component of sickle cell anemia can go for intravascular hemolysis. So this we will discuss tomorrow in our class on sickle cell anemia. Okay, so today we have discussed so much. So tomorrow at 1 p.m. So if you all have any more doubts, please add in the comment section. I will come back tomorrow and I will clear your doubts then. Okay. So 1 p.m. we will discuss on sickle cell anemia. Today at 4 p.m. in the special class, I will be discussing on the rheumatological disorders, diseases in childhood, part 2. In children, part 2. So it will be I'll be concentrating more on juvenile dermatomyositis and scleroderma. Okay, so these are the two main topics I'll be discussing on in the special class at 4 p.m. today. Yeah. Thank you, Ganesh. Okay, so this and tomorrow, that is tomorrow is 9th, right? 9th, 7/20. This is 8/7/2020. Then on 10th here in YouTube, I'll be taking a class on aplastic anemia, so especially the Fanconi anemia. Okay, so Fanconi anemia. So I will do two parts. One part, first one on 10th and another on 11th. Okay, aplastic. So here on 10th in the special class, I'll be taking a class on Kawasaki disease. So that will be at 4 p.m. Okay, so this is the topic discussions. So remember, so if there is any more doubts, please write in the comment section. I'll get back tomorrow. So first we'll discuss all the doubts and then we'll go ahead with the topic per se. Okay, so yeah, so as I always say, study well, daily you study, avoid social media, sleep early and wake up early, and discuss with your study partner for at least half an hour to 1 hour, which will help you to remember better. Okay, so stay safe, stay healthy, and good luck. Okay, and another very important thing, use my code Shilpa10 to get a 10% discount. So that is very important. Only that will help me to stay in this platform for a longer time. Okay, so good luck.